Good afternoon, everyone. Happy New Year, and welcome to the Health Equity Jam session. It's good to see all of you, and I really enjoyed that music. I don't know about the rest of you, but that's like one of my favorite songs. And I have a great niece who it takes dance, and her dance studio, they did a dance to that number. They were so cute. So every time I hear it now, I think about them. But anyway, so thanks for joining us. We have a wonderful program planned today with some two fabulous speakers. I'm going to basically start out with our traditional fun facts about our two speakers, and then give you kind of the more like traditional introduction with all the professional like accolades and everything to give them their props. But first, yeah, let's start out with some fun facts. So, yeah, please introduce yourself in the chat if you're new, and if not, that's okay. We're still happy to see you. So, the first fun fact I want to start with is one that I think is particularly funny. But our two speakers actually have a fun fact that is common to both of them. And I would pretend like it wasn't common to me too, but it is common to me too. So the three of us have something in common that we all love. So I would love for you all to take a guess at what that might be. So put your guesses in the chat, and we'll see who comes up with the right answer first. It's not a trick question. Oh, wonderful. We have some people joining for the first time. Welcome. Welcome so much. Oh, from Boston. And also just right here in the house in Baltimore at Johns Hopkins. So, oh, has anybody guessed what we have in common? Oh, yeah. Bing, 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 bing. Well, some of the people on here actually know the speakers, so it's not really that fair. But let's just say it's not dogs. It's food. Our two speakers are both foodies, so I'm going to turn over just to ask each one of them if they have a favorite like type of food, or if they'll just eat whatever. They don't care. So let's start. We'll start. Dr. Ibe, what about you? What's your favorite type of food?
That's a hard question to ask because I love food in general, but I would say I really love jollof rice, and to be inclusive, I love jollof rice from all West African countries. So,
Good answer. Good answer. We don't want to go off on a tangent, on a jollof rice tangent here. So thank you. All right. What about you, Miss Tiffany Scott?
Um, I think my favorite thing to eat would be a cheeseburger, but it has to be prepared correctly with the right toppings and the right bread. Just not any burger. It has to be the right kind of meat, the right amount of cheese. Like I can go on, but it has to be perfect. But yeah, I think it's a burger.
That
Sure.
sounds yummy. I can't tell the last time I had a burger, but that just does sound yummy. Yummy, yummy, yummy. And not a fast food type one either, like a real homemade one. All right. Well, let's see. We're going to go to another fun fact. The way you guys wrote these is kind of hard for me to do a riddle with them. But anyway, well, let's say one of our speakers uh, is well, has been at some point in her life athletic, and did a particular type of athletics. And so, can you guess which one of our speakers and what that sport or that type of activity was? Mhm. Oh, okay. Thanks for not playing. Okay, we've got a guess that is Tiffany. We've got a guess that it's Dr. Ibe, who's a runner, martial arts, um, volleyball. So wait, so who is Benin Dakar? And how did you guess that correctly? Dr. Ibe, you want to tell us what you did, what kind of sports you did, and what accolades you received as a result? We got two
Sure.
two votes for volleyball for some reason, but anyway.
Yeah, not volleyball. I'm not coordinated enough to play volleyball well, but I ran track in high school and I was the fastest girl on my team and one of the fastest in my county.
Awesome. Are you still running?
I run my mouth.
Okay. All right. So let's see. We're going to do one more fun fact, at least one. Well, let's see. One of our speakers, I think if you're a parent, you can relate to this comment. So, uh, one of our speakers has a particular experience with parenting. And so let's see, maybe you all can guess with what that might be. Multiples? That was a good guess, but not. Hmm. Folks are getting stumped here. Well, I know this speaker has something in common with our administrative coordinator, Latoya. So, okay. No, not. We've got people who want to talk about pets here today for some reason. So maybe we'll get to pets at some point, but yeah, not a new mom, but well, okay, why don't I'm gonna, oh, Julia got it, teenagers. Okay. Let's turn over to Miss Tiffany so she can tell us about what her experiences have been with teenagers.
I have a 16-year-old daughter, and if you have a teenager, you should laugh with me because it's going to keep us from crying. You're either going to laugh or you're going to cry. I also have a 14-year-old son who will be entering high school this incoming year. And so parenting has been a joy, but it has definitely been a roller coaster for real. All right. So if you have a 16-year-old daughter, I'm praying for you and I'm laughing with you. All right.
Yep. And what did you tell us about how much they think they know more than you, despite how
Yeah,
many community health workers have you trained?
I've trained over 700 CHWs and CHW instructors, and they still think that they know more than I do. They still tell me, you didn't say that right. You don't know this. You didn't tell them about this. This is a new app. This is AI generated. They still think they know more than I. So, I laugh to keep from crying. That's all.
Oh, oh. Well, I know you guys have a lot to talk about. We've got more fun facts for you, but we do really want to hear from our speakers. So let me introduce them more formally so they can speak. So, well, first of all, Dr. Chidinma Ibe has spent over 20 years. 20 years. I didn't realize that. I guess have I known you that long? But designing, implementing, and evaluating community health worker-led interventions to support members of structurally disadvantaged communities with cardiovascular disease. She's an assistant professor in the Division of General Internal Medicine here at Johns Hopkins and also associate director of community engagement in the Center for Health Equity. And she has joint appointments in the Bloomberg School of Public Health. Ms. Tiffany Scott is Maryland's first certified community health worker and a nationally respected advocate, trainer, and policy leader. She is vice chair of the Maryland Community Health Worker Advisory Committee and co-founder and president of the Maryland Community Health Worker Association. And so she's going to tell us, and Dr. Ibe is going to share with us some of their joint experiences, and they might be sharing some of their sort of individual experiences they've had in practice, research, and sort of policy advocacy in the field of community health worker programs. So without further ado, Dr. Chidinma Ibe and Miss Tiffany Scott, Mrs. Tiffany Scott.
Thank you so much, Lisa. I'm going to start to share my screen so you can all see the slides. But before I do, I just wanted to, oops, sorry. Thank you, Dr. Cooper and others in the Center for Health Equity for allowing me and Tiffany the opportunity to talk about work that we've done. We've had well, I'll just say from my end, I've had the privilege of working with Tiffany for several years at this point, which I can't believe it's been as many years as it has. And we're going to highlight one of the projects that we worked on. So the title of our talk is Centering Community Health Workers as Leaders in Community Engaged Research, the AFFIRME project. So this is just an overview of what we hope to address in our time together. We'll provide a brief overview of the pilot study, AFFIRME, which stands for A Family First Initiative in Realizing Medical Social Equity, so the AFFIRME project. And then we'll highlight the role of community health workers that they play in developing, implementing, evaluating, and disseminating AFFIRME. And then finally, we'll conclude by discussing some recommendations for how to engage community health workers throughout the research life cycle. Anything to add, Tiffany?
Nope, you got it.
So, if any of you have ever come to a talk that I've done on CHWs, I always include this slide because it really helps to contextualize why community health workers are important. And I think that there are a number of people on this in this meeting who have either worked with community health workers, who are community health workers, or just have some familiarity with them. But the picture that you see here was taken I think actually 10 years ago at this point, if I'm not mistaken, in the Madison East End community here in Baltimore City. And it's less than a mile away from Hopkins. One of the things that is striking about this particular neighborhood is that it really reflects the demographic, the financial, and health profile of the types of communities that CHWs live in and or work in here in Baltimore City. And this is a quote from a community health worker. Okay, the quote is from Tiffany. And it's one of my favorite. This was a report that was done for the Able Foundation, and Tiffany was one of the people I interviewed for this report. And I love what she says here, that it really showcases why community health workers are so essential, that when we think about the predominant medical and public health paradigm of research and practice, it's always what's wrong, like and the leaves are what's wrong. And what CHWs do is that they not only identify what's happening in people's lives, they get to the fundamental root causes of patients' struggles to maintain their health and really address these social risk factors that prevent people from being healthy.
All right, so who are CHWs? What is a community health worker? You'll hear various terms, but just to really plainly, CHWs are just public health workers. We are trusted members of our community, or we have a really, really close connection to certain communities. And with this trust and relationship, we're able to provide education, we're able to help navigate, we're able to support, we're able to just be a resource to the community where they're not afraid to share some things that they may feel that other health professionals may consider to be judgmental. And so, because we have that trusted relationship, because we understand that community, we speak their linguistic code, right? We're able to understand some of the social barriers that that community face, as well as the assets of that community and use them to empower the community members to fight another day, to advocate for themselves, to not be afraid to share with the physician, to share with others their likes or dislikes. And so that's what CHWs really have a good take on life, I would say, when it comes to working in the community. And it's a special sauce. You can't, I hate to say it this way, you can't make a CHW. Like it's it's a part of who you are. It's a part of your DNA. It's a piece of piece of fabric of who you are as a person. The training just kind of helps build that infrastructure, the do's and the don'ts. But being a CHW is just something that you just wake up and you just innately have these skills and this love for your community and wanting to see them do well in life.
That's really beautifully said, Tiffany. And I just have to say, on a personal note, aside from being a close friend, Tiffany is also my CHW and asks me why I haven't been eating what I should eat or getting enough sleep. And in fact, did that earlier today. So it's true that it is indeed a calling and that there are certain people who are really well suited to be a community health worker, to Tiffany's point. And so when we think about CHWs, I'm approaching this from a researcher's perspective where I became interested in community health workers at a very young age. So when I graduated undergrad, the first program I worked with was with community health workers, and that was in 2003. And at that point, the evidence base for CHWs wasn't as robust as it is now. I remember that was the year that unequal treatment came out from the institute or the institution formerly known as the Institute of Medicine. And they talked about the role that community health workers could play, or the promising role, that was how it was framed, in addressing health disparities. At this point, we now know that everything that Tiffany said has been observed in the evidence, that they strengthen linkages between health systems and communities, and they really help to mitigate the impact of adverse social determinants of health or social risk factors. We also know that exposure to community health worker-led interventions is associated with a host of positive outcomes, whether it's health outcomes related to chronic disease management, outcomes at the individual level across the life course. And at the same time, when you talk to a community health worker, you will note it, you'll notice that although they intervene for individuals, they are often focused on the family unit at large. And that was one of the gaps that my colleague Nakia and I identified as an area that we could potentially address. So even though the actual CHW model is underpinned by this goal of building capacity on multiple levels from the individual all the way to the community, the evidence base isn't always aligned with that. And there are a lot of reasons for why that's the case, but that we don't have to talk about that today because we're going to talk about our own stuff. So to that end, I mentioned Nakia. So Nakia is a really close friend and a core faculty member here in the Center for Health Equity and an associate professor in pediatrics. We met several years ago, I think over 10 years ago at this point, through a mutual friend. But we bonded because we had a shared mentor, and that was Dr. Lisa Cooper. So when we realized that we had the same mentor and realized as well that we had overlapping interests in health equity and health disparities research and really thinking about community-based strategies to address these inequities, we started kind of thinking, well, we would love to work together. The opportunity presented itself in 2021 through a funding mechanism through the Johnson and Johnson Foundation. And we leapt at the opportunity to develop and implement a CHW-led family intervention. And as an aside, I really just want to acknowledge and appreciate Dr. Cooper's role in helping to facilitate that because the funding came from Johnson and Johnson, but it actually came to the center because of another Johnson and Johnson funded project that they held in high regard and wanted to continue working with the center. So I think it's important to note that. And at the same time, when we were thinking about this project, I told Nakia, I have this really good friend. Her name is Tiffany. She's president of the Maryland CHW Association. We've got to get her involved. And we both were very keen to do that because we knew that if we were going to have a program or an intervention that had CHWs as interventionists, they needed to be involved in the study team and in every aspect of the project.
And so here I go as just a CHW. This was one of the very first grant projects that I had an opportunity to participate on. And boy, was it the best project, being able to work with people that I respect. I've always respected Dr. Ibe. I didn't know Dr. Showell too much, but after that first meeting, I was like, okay, I love her too. And so just having the opportunity to work with them and to partner with them, and that my voice as an expert, as a subject matter expert, was utilized, even when it came to interviewing CHWs and thinking about the job position. What would it entail? They allowed me to spearhead that. They kind of took the second seat and allowed me to kind of write that out, and what I thought would be useful in this position. And so um, Miss Muriel Rogers, she was one of my former students through CHW training, got the position. And so it was a wonderful experience for me as a trainer to not just train someone, but have the opportunity to work alongside them. And so this was just a beautiful experience that I wish most CHWs and researchers could have the opportunity to do.
Yeah, thank you for saying that, Tiffany. And I do want to say from the research side, it was a no-brainer to ask Tiffany to help spearhead that because as you can tell from hearing her speak and even from the previous slides and looking at this slide, she has such deep and extensive experience, not just within the state of Maryland, but nationally. When Nakia and I interviewed with Miss Muriel, we knew right away that she was the perfect fit. She embodies everything that Tiffany said about how community health workers are born, they're not made. And what we did in the context of AFFIRME in terms of training, which Tiffany also took the lead on, was identifying gaps that we could fill through the training to build her professional capacity. And that leads me to just give you an overview of what our aims were for AFFIRME. You could probably draw some conclusions about what our aims were just based on what we're talking about. But essentially, our driving objective was we wanted to employ a family-based approach to address health-related social needs among patients in the pediatric primary care setting. So we had three aims that we proposed to Johnson and Johnson. The first was that we wanted to co-develop and implement this family-based CHW-led intervention in partnership with colleagues from FQHCs and hospital-affiliated clinics. We also wanted to characterize the impact of this intervention among families with complex medical and social needs. And we were really interested in, what are the patient's psychosocial outcomes? What are the social risk factors? And to what extent did the community health worker help link them to resources and that they needed? And then we wanted to also identify barriers and facilitators to implementing this intervention because we felt that doing so could inform broader scale implementation in FQHCs here in Maryland and New York. And I just want to note that the reason we put New York is because when we were drafting the proposal, Johnson and Johnson indicated that they really wanted us to think outside of Maryland and to consider other partners. So we were fortunate to have a good connection with the colleague at NYU, Dr. Nadia Islam, who works with community health workers there. She connected us to Family Health Centers, which is um, an FQHC health system affiliated with NYU. And then again, here is just some details about the AFFIRME project. So we based this project at the Harriet Lane Clinic. The way that we engaged our colleagues at NYU, or I'm sorry, at Family Health Centers rather, was that they kind of served as advisors. So when we were developing pieces of the intervention, they were working alongside and ensuring that what we came up with was aligned with what we wanted to achieve. Um, and this study design to kind of test our hypotheses was our prospective single site pre-post cohort. So this was not a randomized trial. This was really a pilot study, almost like a proof of concept type of intervention. One thing I also want to note as you look at the eligibility criteria is that we were very broad in the medical conditions that we included for inclusion criteria. And Dr. Cooper warned us about doing this. And we did kind of see some of the potential drawbacks for that, which we'll touch on in a minute. But I'll also say that when we were thinking about how we wanted to do this, we really wanted to test what would happen if we had a disease agnostic model where it was community health worker led, bearing in mind that all of the fundamental drivers of poor health, they traverse all health conditions. So that was kind of our rationale. And you can also see all of the wonderful partners that we were able to collaborate with.
All right, well, I'm having a hard time with no mouse today. But some of our guiding principles was the co-creation. One thing, like I think I said earlier, is that it was no big I's and little U's within the Affirm team. We all worked together. Everybody's voice was just as valuable as the next person. So that co-creation, sharing, the shared learning that came from CHWs to researchers, from researchers to medical doctors to CHWs was just a beautiful experience. We were very, very transparent in the way that we felt and what we thought. It was an open, safe space for us to share what we really, truly thought without feeling judged or feeling less than. And then there was just so much trust within inside the group and amongst all of the members.
I completely agree. And the other thing that we really valued was trying to authentically engage with patients and families, CHWs, providers, and other partners, because we really wanted this to be something that engaged multiple people and addressed um, something that we commonly see when it comes to community health worker interventions, but also community engaged research at large, which is that even though we might say that we're doing certain things in terms of engaging people throughout the life cycle of a study, from inception to, thinking through the intervention protocol and delivery strategies to evaluation and dissemination, when you look at what actually transpires, that doesn't always play out the way that it should. So again, we really wanted to make sure that authentic engagement permeated every aspect of how we conducted the project.
And another great thing, another great guiding principle was just really uplifting the CHWs. It wasn't about what can the CHW do for us in this project. It was more or less of what can the CHW do in general for all populations, all walks of life, all races, everybody that comes through the door. What can the CHW do to address all the families that came through that were needed? Even those that participated in the study, not just the child and the parent, but the entire family. And so that was some of our guiding principles that we had through the Affirm project.
And so, alongside what Tiffany and I just talked about, we really tried to employ a participatory intervention development process. So just kind of the specifics of how we aimed to achieve this was we co-developed the intervention through monthly meetings with our partners at NYU and family health centers. I meant to say family health centers. Um, and you can see the retreat that we had in 2022, which was really fun and filled with good food. I just have to put that out there. We went to New York and met with the group, and it was great. And then the following year in September, we were happy to host them and also treat them to the great food here in Baltimore City. But in these meetings, it was not just, you know, talking through the mechanics of what the intervention would include. We used it as a chance to build relationships and to facilitate what Tiffany really articulated so beautifully, which is that bidirectional learning and capacity building. I'll say for me, and I think a lot of the other researchers on the team can attest to this. We learned so much from Tiffany, from Miss Muriel, and from others at NYU who had close proximity to CHWs. And I hope that they learned from us as well, but we learned a lot about how to put together an intervention that truly meets people where they are. And to that end, we also collaborated with Hopkins Community Connections, which is based at the Harriet Lane Clinic and is also at the East Baltimore Medical Center. It's a program that uses kind of like a community health worker type of model to help those who come into the clinic with different social risk factors get connected to needed resources. So when we partnered with them, they helped us with the recruitment process. They also actually helped us fund Miss Muriel's position as well. So she split her time between the HCC program and AFFIRME. And one of the main things that we'll talk about in our discussion today is the role that the CHWs on the team played in designing the intervention and the implementation strategies, as well as other things that are related to the project. So I'll give another, just talk about the recruitment as well, and Tiffany will also weigh in because this was an interesting experience for us. So initially, when we were thinking about how we wanted to recruit people to be part of AFFIRME, um, I made a flyer through my good friend Canva, and we thought it was so appealing and we were so excited. And I see her in this meeting, so I also wanted to just um, thank Dr. Brenda Pennant, who was the research program manager for AFFIRME. She played a pivotal role in facilitating all of the things that we're talking about, not just in the implementation of AFFIRME, but all of the other aspects around scheduling meetings, shoring up the recruitment process, et cetera. So we were like, okay, we're going to put this flyer up. The flyer didn't attract as much interest as we thought it would. So then we said, okay, let's work with HCC and use the way that they read. I'm sorry, we'll use them rather as kind of the pathway for getting people into AFFIRME. And that kind of worked, as you can see here. So we were leveraging the infrastructure they already had to get people into the Hopkins Community Connections program, but that still wasn't great. So then Miss Muriel was like, look, what you guys are what you guys are doing is not really working. You need to let me help you recruit. I'm already building relationships with people. If we find someone that, fulfills the eligibility criteria, I know I'm already building relationships with some of the families here. You should tap me to help with the recruitment. Tiffany, I know you have more to add, but that's a little bit of a summary of some of what happened.
Yeah, and so I think when Miss Muriel was tapped in, I think it was some hesitancy there, like, are you sure? But once she was tapped in, exactly what she said. I built these relationships. I can get these families to say yes. And they did. They began to trickle in a little bit faster than they were initially. And so I think that really makes a difference when you actually listen to the CHW. You listen to the person that is plugged into the community, that can speak linguistically that code of that community, that looks like that community, that has that trust, that you just can't purchase. And I think that really made a difference with the families coming in and being ready and willing to work with us.
Yeah, Tiffany put it perfectly. And really over the next several slides, we've laid the foundation for what led to Affirm's creation and all of the different nuts and bolts of putting it together. But what we really want to talk about are these four areas where community health workers, namely Tiffany and Miss Muriel, really spearheaded or worked alongside other members of the team to support intervention protocol development, think about organizational readiness to house a program of this type within the Harriet Lane Clinic, um, addressing evaluation strategies or weighing in on evaluation strategies, and then, of course, the dissemination approaches for AFFIRME. So first, just thinking about the intervention development. When you think about what community health workers do, the intervention that we came up with is pretty consistent with work that we've done in the Center for Health Equity through previous trials led by Doctors Lisa Cooper and Jill Marsteller and others, where the community health worker does an assessment. Um, there is a We try to use different protocols that provide guidance on how they will engage with a patient. Um, and we tapped into that experience, but really a lot of what we drew from was what Tiffany and Miss Muriel said. So we would just sit down with them and we would be like, okay, this is what we're thinking, what the intervention should be. What do you think? And we would go back and forth and figure out, and then nail down what it should look like, and then put it together, try to codify it so that it provided assistance to Miss Muriel. And one thing I just also want to call attention to is when we put these protocols together, we were thinking not only about Miss Muriel, but the potential for future work. So, what would other community health workers in similar positions need to do? We tried to really delineate the desired frequency of encounters between Miss Muriel and the participants in the program, the different processes of linking families to the resources that they indicated they needed. And then this last point, which is really critical, was we tried to generate scripts and prompts that would help them. And I'm laughing as I look at Tiffany because when we were thinking about this, we remembered that I think I had drafted something and Miss Muriel was like, that's not how I talk. And so we had to go back to the drawing board and refine it. Tiffany?
Yeah, I think though that was one of the um, great parts of working with team members that allowed the CHW voice to be heard. Um, Researchers talk research, right? You guys use your own lingo, and us from the community, we have our own lingo. And so trying to merge the two to make sure that all the questions were asked. I know in CHW training, we have a way of asking questions to get the answers that we really want. And some of the questions that were on the script didn't necessarily give us exactly what we wanted. Such as, for an example, someone may say, did you eat dinner? I don't necessarily want to know, did you eat dinner? I want to know what you ate for dinner. Because if you tell me I ate Cheetos, I know you really didn't have a quality dinner, right? But if I ask you, did you, and you just say yes, then the assumption is that you ate a balanced meal. So that was some of the things that we kind of discussed and we kind of went through when we were coming up with the scripts and the prompts. Not that anything was wrong, it's just the way that CHWs communicate with the community to ask the right questions instead of doing two questions. We can kind of wrap it up in one, pretty
Yeah.
much.
And alongside everything Tiffany said, and this is why I wanted to emphasize the point she raised earlier about the learning that happened. That was one of the most critical pieces for me and for other study team members was really learning how to create documentation tools that are accessible for a community health worker that provide the type of guidance that can help someone delivering an intervention but doing it in a way that is actually like grounded in people's real lives. And one of the ways that we did this just from kind of like a practical perspective was that when we would have these meetings, we would draft an agenda. Typically, Dr. Pennant would help draft the agenda, and then she would circulate it to the group, and everyone would weigh in to share meeting priorities and key discussion points. And that was the process by which, or at least that helped to initiate the process of determining what the intervention protocol would look like. One thing that I wanted to just ask you, Tiffany, is just reflecting back on that experience, what skills do you think a researcher or a public health practitioner would need when it comes to developing an intervention like this with a community health worker?
Well, one, they need to pick the right CHW.
Mm,
I think that's a big step. Picking the right CHW that doesn't have an issue with um, speaking up and advocating. And when you see something not necessarily the right thing or not going in the right direction, just being willing to say something. I also think the researchers need to be great listeners, really active listeners, and not listen to what you want to hear, but listen to all of it. Don't just hear the beginning and then just cut us off, but just listen to us all the way through. Most CHWs are very long-winded. We love to talk because this is what we do all the time. But listening to our rationale, why we believe the way that we believe, or we think this will work this particular way. Not everything may be implemented, but it will definitely be good for researchers to hear, as well as having CHWs there from the beginning to the end,
mm.
um, giving us a seat at the table when you think of, aha, I have this really good idea. I think it would be great for CHWs to be there at the beginning because a lot of things that you may think may work from the beginning, we can probably tell you 9 times out of 10, we did that last year. That didn't work. That community, they just had this happen. They're not going to be willing to do that again. This may have happened recently. There may have been something tragic. They're just not going to be willing at this moment to participate in this study. It's too soon. It's too early. And so I just think really, really listening and not taking things personal. Oftentimes we talk about being overworked and underpaid, and that kind of ruffles some feathers sometimes. People kind of, oh, but don't take it personal. We're just speaking from our experience. We're speaking from some of our CHWs are still getting paid $15 an hour for the great work that they do. And so that's always a conversation about salary, about compensation. CHWs are going to do the work regardless, but being compensated for what we do, I think really makes us feel like we are valued members of the team. But that's some of the um, skills I think that a researcher would need to really hone in on when asking a CHW to be a part of their research study.
Yeah, thank you so much, Tiffany. And I really appreciate everything you said in it. You made me think of something else too that I think um, is related to this idea of being an active listener, which is, when you have a team that consists of people from different backgrounds, whether they're community health workers or, other types of frontline healthcare workers and researchers, it's really incumbent on the people who are leading that study to be attentive to what people know and what they don't know.
Hmm.
So on our end, what we did know was how to identify what type of instrument to use to collect data on a specific construct. So for us, for instance, and I'm kind of skipping ahead a little bit, but you'll see it soon, we were interested in family functioning because that was one of the main things that we thought the program would help with. So we identified an instrument that captures facets of family functioning. I didn't actually know about it until we did AFFIRME. It was Nakia who introduced it to the group, and she explained it to all of us so that we all had a shared understanding of what
Hmm.
that meant. The same thing with things like the PHQ-9, which
Yep.
is a tool that's used to measure depression and depressive symptomology. So again, for those of us who are on the researcher side, being mindful that not everyone is going to be familiar with what you're familiar with, and taking note of that and taking the time to explain things so that everyone is on the same page.
Absolutely.
I think another way this really played out was what we were thinking about in terms of organizational readiness. So, one of the things that Tiffany and I had talked about a lot over the years, and what came up in other conversations with other people who work closely with CHWs, is this idea that although there's interest in community health worker interventions, a lot of the organizations that house them are not equipped to do so and to really optimize what CHWs do. So we were thinking, okay, here we are at the Harriet Lane Clinic. They have a lot of residents who come through. What do we need to do to make sure that they are going to be able to engage with Miss Muriel and with any other community health workers that come into the program? And so what Tiffany and I did was that we put together a slide presentation on all the things that we wanted to teach them about CHWs, about, you know, how to enlist a community health worker in various scenarios. And what you see on this slide are a couple of the slides that we showed to that group. Tiffany?
Yeah, I thought that was such a wonderful experience, being able to have conversations with these new providers that are new onto the scene. CHWs have been around for forever. We've been around for forever, but it just seems like um, new professionals don't quite understand the unique role that CHWs bring to the table. And so having the opportunity to talk to these new residents, to talk about CHWs, to answer the questions, it made me as a CHW feel not just seen, but actually heard because they were really, really engaged. They had some really, really thoughtful questions. It wasn't just, she's just another person in the office that'll answer the phone or that can just do a simple referral. It was like, you can tag her in. Like, if this is what you're looking for, she can come in or he can come in and they can be your eyes and your ears outside of the office. They can tell you what you're not able to see with the person just coming in. And so I think that experience talking to them, getting to know them asking questions really made it seem more like this is something that we're implementing into the clinic versus this is just another grant opportunity. This is just to finish this project and then we're done. It was more as this is the lifelong trajectory of what CHWs will do here at Harriet Lane. So when you see them, this is their unique role. This is how you utilize them. And so I felt seen, I felt heard, I felt like my voice mattered. And I know Ms. Muriel felt the same way that her voice mattered. It wasn't just about the AFFIRME participants. It was about anybody that came through the door that needed assistance. I'm here. I am the resource.
Yeah, I loved everything that you said, Tiffany, because I think both the goal that we had was really to help socialize this idea that primary care teams need community health workers. And to your point, it wasn't just about the AFFIRME project. It was these are residents who are going to graduate from their residency programs and go to other places. So will they have the skills needed to work with the community health worker if the opportunity presents itself to do so? And what can we do, even in the short time that we had with them, to give them some insight as to what that might look like in their next place of employment? And I will also just add too that from my perspective, what I really loved about that doing the training together was I've had experience teaching students and I enjoy teaching them, but I learned a lot from Tiffany and how she approached teaching, as well as the way that we were both able to bring together our collective experiences and expertise to help, you know, help people understand the importance of what community health workers do and provide concrete guidance on how you use or tap into a CHW in your clinic. I this on the slide, you see what would a CHW do in this scenario. We were giggling when we were working on these scenarios together because we were just trying to be as creative as possible, but also, really speak to what actually happens. And I shouldn't say we were giggling because we took it lightly. It's just that it was a fun experience, to be quite frank. It was me, Tiffany, and Nakia. We sat down and we tried to draw up scenarios that we knew that people would be likely to face and how to navigate them with a community health worker. And then the other thing too was that we really tried to make sure that both Miss Muriel and Tiffany, and even our colleagues at family health centers, were involved in developing and refining the tools that we use to monitor what happens. So all of the different intervention, data collection, tracking tools like a baseline assessment or follow-up forms, some of which were adapted from previous studies that were done in the Center for Health Equity, um, as well as the evaluation strategies. So, what types of questions did we want to ask caregivers? What types of questions did we want to ask those who were at the Harriet Lane Clinic and worked closely with Miss Muriel? What were the perceived barriers and facilitators? And I'm not sure if she's here, but we had three exceptional research assistants on the team. Shruti Banner, who is now a doctoral student at the University of Iowa, Julia Wang, who is now a research assistant with the Center for Health Equity and will soon be a doctor. Maybe she'll treat me when she grows up. She is grown up, I'm sorry. And and Shannon Fuller, who is a PhD candidate at the School of Public Health. And Shannon in particular did an amazing job of drafting the interview guide for AFFIRME, but she did it in very close consultation with everyone on the team, particularly Tiffany and Miss Muriel. Is there anything you want to add? Okay. And then the other thing too, and I see some people who know me smiling. Look, if Chidinma Ibe is around, a logic model is going to be made. Okay. I love a good logic model. And for those of you who don't know what a logic model is, it's essentially a tool that allows you to kind of map out the conceptual and practical pathways between the inputs or the resources that you need for a program, the set of activities that you hope to do, the evidence of having done those activities, which are the outputs. And then we generated short-term, intermediate, and long-term outcomes. We did this at the outset because we really wanted to clarify all the different activities that we aim to do through AFFIRME, and we broke them up into two different categories. There was what the CHW intervention would involve, and then there was actually the relationship and partnership we wanted to build with each other from the Hopkins side and the Family Health Center side. So we're working on a paper on that right now. So if you want more details, stay tuned. So the next few slides, we're just going to tell you what ended up happening with AFFIRME. So did we achieve some of the outcomes that we wanted to? So from a quantitative perspective, we collected a lot of quantitative data. You're only seeing a snapshot of it because we're still in the process of, viewing it and understanding what the data is telling us about AFFIRME. But we do have some preliminary findings in terms of the outcomes of interest. So for AFFIRME, we had 26 households who were involved in the program. And those households had children who were 8 to 17 years of age who sought care at the Harriet Lane Clinic. And in terms of discerning the impact of the program on these outcomes, we used paired t-tests to assess the difference in outcomes between baseline and follow-up. And when I say we, it was actually Shanyan Cheng, who is a statistician and part of the Center for Health Equity, and she was wonderful to work with. And I just want to note some of the exclusion criteria in case you're interested, which is we excluded people who couldn't give informed consent. We also excluded people who turned or were about to turn 22 during the data collection period. And that's because 22 years old is the upper age limit for patients seen at the Harriet Lane Clinic. We excluded those who had hearing, language, or visual impairments. But one critical exclusion that we really debated was we also excluded people who didn't speak English. So we know the Harriet Lane Clinic has has a growing population of Latinx, people across the Latin American diaspora. But we knew that Miss Muriel didn't speak English, so we were trying to confine the eligibility criteria within what we knew Miss Muriel had the capacity to do. I think if we were to do this again and we had more than one CHW, we would want to include those who are Spanish speaking. Anything to add, Tiffany?
Yes, Miss Muriel spoke English. She didn't speak
Mhm.
Spanish.
Oh, I'm sorry. Did I say the, I might have said the wrong thing. Thank you. And so here's some of the characteristics. The mean age was 43 years for the caregivers, mostly those who were part of the project identified as African American and non-Hispanic or Latino. Um, and most of them were, identified as female. One of the striking things is when you look at the annual income. So um, of the 26 households, the majority of them, the vast majority of them, about 81% earned less than 59,000 a year. So, and within that, half of the people earned less than 30,000 essentially. So we were dealing with or supporting a group of people who were facing poverty and all of the different social risk factors associated with poverty and low income. Then for the children, what we were able to look at was what types of health conditions were they diagnosed with. So the mean age for the children who were part of the AFFIRME program was 12 years. There was actually an interesting and almost even split between those who identified as male and those who identified as female. So a slight majority identified as male. When we look at the different conditions that were included, um, we see that most of them had a respiratory condition. I'm sorry, not most of them, 22% of them rather had a respiratory condition, 21% had a neurological or developmental condition. And you see other ones that are listed here, including gastrointestinal, dermatologic, mental health and behavioral health, allergies, endocrine and metabolic conditions, and other. And then other would just be renal conditions or musculoskeletal conditions. So you can see that there's a spread with the health conditions, and that is going to come up when we look at the outcomes. Oh, Tiffany, you're on
Yeah,
mute. Oh,
I'm
okay.
I'm here. Just me and
Okay.
I told you I don't have a mouse today and it is driving me insane. All right, and so here Shannon did a really, really phenomenal job taking the lead and developing the interview guide. Ms. Muriel and myself, we had the opportunity to review the guide, to make some suggestions, to make some changes. to kind of really sink it in. And it wasn't, we need this back in 24 hours. They gave us time to really internalize, to kind of play with it a little bit, to kind of role play. Essentially, me and Miss Muriel went back and forth with a little role play. Like, if you say this, how would you follow up? How could you ask this question? So they gave us some time to really look at the guide to make sure it was actually what we thought as CHWs will really get our community members to participate and really have that big impact on the project.
Yeah, that is so true. The feedback that Miss Muriel and Tiffany provided for all of the interview guides was really critical. Tiffany is talking about some of the interview guides that were done, I think, for the patients and caregivers, but we also are, and by we, really Shannon led this effort. She also conducted interviews with staff at the clinic too. And although we're not going to share some of those findings, I wanted to highlight that was really important because Miss Muriel played a really significant role in ensuring that all the domains of interest were included and the ones that were really relevant to her. So things that she was even interested in understanding about how she was perceived. So, the demographic characteristics for the caregivers who participated in the interviews are pretty similar to what we saw just across the board for those who are part of the um, program. And there were some key themes that came up. Um, Three of them were focus on social needs, the value of emotional and instrumental support that participants ascribed to working with Miss Muriel, and then the benefits that they felt they derived as a result of working with Miss Muriel. So they have appreciated that the AFFIRME program or project focused on health-related social needs. And one of the things that is interesting about this finding that is relevant to some of what we found for the quantitative results is that the caregivers were already pretty strongly connected to the Harriet Lane Clinic, which means that they were already, integrated into the clinic. They were already getting the care that they wanted to get for their children. And so the intervention didn't make much of an impact on medical appointment attendance. Where they really felt the impact was the experience of going to the clinic and the experience of feeling more comfort and doing those visits with their providers as a result of working with Miss Muriel. And then similarly, they expressed that the emotional and instrumental support that they got from Miss Muriel was really important, that she provided validation, that to Tiffany's earlier point, they felt empowered and a greater sense of confidence in their ability to support their children's health. Um, and as you can see here, it had ripple effects not only for health management, but also for school and for socialization. One of the things that I loved about this particular finding is they talked about how CHWs reduced the mental load in terms of managing all these responsibilities around medical care and household needs. And then finally, and this is kind of a latent hypothesis that Nakia had, that working with the CHW helped the caregiver to think about their own unmet health needs. So one of the reasons that Nakia was really interested in thinking about the family as a unit of analysis for a study or for a project was this idea that sometimes parents are not as concerned about their own health. They're more concerned about their children's health. And if they're able to support their children, it might make them more interested in managing their own health. So here are some of the illustrative quotes.
Yeah. As we look at some of the quotes, and I won't read them word for word, when we talk about research and we talk about the conclusion and we look at the outcome, sometimes we don't get the outcome that we expect to get, But from the CHW perspective, we received the outcome that we expected. If we can help one person be better, do better, see another way of doing something to conquer a fear, to get a closer relationship with family members, to get closer with their provider, to be able to advocate for themselves, that is a win for us. And I believe Miss Muriel did such a phenomenal job of making the clients and the patients feel seen, to feel heard, helping with resources. As the first caregiver said, she talks to me. She got me all the way together. That's one of the terms that's in the community. She got me all the way together, which means she told me about myself and told me how I can get back on track, how I don't have to stay where I am. There's another option out there for me. There's somebody that's going to support me. It's not about just throwing me resources, because anybody can find resources. It's about walking me through. And as caregiver two talked about, she didn't just tell me how to do it. She showed me. I was able to watch her and then model after the behavior that I saw her exhibit. And so I thought that was just two great quotes. And here's two additional quotes that I think that was really, really phenomenal. The first one says, "This program, it makes people feel like, okay, I'm being heard. I'm being listened to." And that is one of the things that most community members feel like, is that the medical providers and the doctors, nobody's listening to me. I'm saying I'm hurt, and you're saying you don't see the hurt. You don't see it. And not everything is something you can visually see. Maybe my heart is broken. Maybe I'm going through a mental crisis because I need one, two, three, and everybody keeps giving me four, five, six. Nobody's listening to me. And so just even helping with budgeting, how to make $1 out of 15 cents. I mean, some of us understand robbing Peter to pay Paul, and we don't even sometimes have the money to rob Peter because we never had any from the beginning. And so understand the uniqueness of our community members, understanding some of their struggles, and being able to help with some of the things that we think is common sense. Everybody knows how much you get during the month. How do you budget? How do you make these ends meet? Not everybody had that skill or have that skill. So even teaching how to clean a home or grocery shop, those things I think really put a stamp in what Miss Muriel was doing for the community members and the clients at Harriet Lane, as well as the young lady on Caregiver 9 talked about just being connected with her therapist, being able to have a closer relationship with her children, to be able to talk to them, all out of just Miss Muriel being open, being vulnerable, sharing, listening, actively listening. I think really, really made a true difference with inside Harriet Lane.
Yeah, I completely agree. I mean, Miss Muriel is so phenomenal in so many ways. And she's not here probably because she is working right now. But I think another thing that strikes me about this quote from the Caregiver 9 is that they recognized, hey, you're not just focusing on one person in the
Mhm.
household, you are focusing on the entire family, which is really, it really speaks to what Miss Muriel was able to do with the family she worked with. And for the sake of time, we don't have much more to go, but we want to make sure we leave room for questions. So I do just want to say that we didn't really see an effect in the primary outcomes of interest. And we have some thoughts about why that could be the case. We think that, we had a small sample size. The intervention length was only about 4 months long, and that wasn't intentional. That was a function of some of the challenges around getting Miss Muriel situated in her role, as well as recruitment, because if you think of the time frame, where it started in 2022 and went to 2024, it coincided with COVID, and it also coincided with rising disinterest in participating in research. So we suspect that may have had an impact as well. But the other thing too is we've been thinking about maybe we should have selected a condition and looked at it from that angle instead of having this diffuse disease agnostic approach. But on the other hand, when we actually look at the qualitative data, we see that AFFIRME was viewed favorably by the people who received it. It was also reviewed very favorably by staff at the Harriet Lane Clinic as well. And so I think what our takeaway is for future work is how can we align what we learned from the qualitative findings to specific quantitative outcomes if we were to have an opportunity to extend this to or do this type of work again. And so now we're at the last bucket, which is dissemination. And there are a lot of different ways that Miss Muriel and Tiffany were involved in helping to disseminate the AFFIRME model and just the role of community health workers in pediatric settings in general. So, Tiff.
Sure. So one of the things that we did was have a symposium. The symposium was absolutely phenomenal. We had CHW speak from personal experiences, talking about their lives, talking about the lives of others, helping. It was just a great symposium, just a networking of individuals that were like-minded, that wanted to help the community and being able to share some of their strategies, was able to share some hardships, some challenges, and also able to share some wins, some things that really did go well. People that were really in their corner, some really good stakeholders and allies that really supported CHWs that maybe we didn't know about, or maybe we kind of they were overshadowed by all the other things. And so it was a great, great day for that symposium. So many gained so much from what was said from us as the CHW panel, as well as other CHWs and other professionals there.
Yeah, I just wanted to say too, the symposium really was awesome. It was June 26, 2024. It was just an incredible experience. The pictures that you see here are from the symposium. So there was a photography exhibit that featured pictures from a photo voice study that some of us who were in the Center for Health Equity partnered with the Maryland CHW Association to conduct. And the person that you see featured here is a CHW extraordinaire, Mr. Gregory Rogers or Greg, who is now, I think, he was at a different clinic and now he's with a completely different health system.
MedStar.
Yes, he's at MedStar, thank you, which is awesome. So that was a really incredible way of being able to galvanize interest in and support around incorporating CHWs into pediatric settings. The other thing too is, we are in an academic environment, and so we understand too that in as much as it's critical to disseminate to policymakers and to practitioners, we also have to have academic products. So these are the things that we are preparing to submit and actually submit this year. Some of these things are in the tail end of being written, which is great. But one thing that is critical is that, Tiffany and Miss Muriel have been involved in all of these papers, and they are going to be co-authors. So that really leads to there are two kind of primary last slides for content. So if you are someone no, I'm just kidding, just copying that commercial. If you are interested in having a study or leading a study with community health workers as co-investigators, what kinds of things should you do? These are just a few tips, some of which we both learned along the way. One, leveraging every meeting to ensure that community health workers' expertise and experiences are uplifted because it builds our capacity on the research side to understand what they're doing, and it will build their capacity as well to not only articulate what they're doing, but to determine how to measure it in an effective way. Study teams that have, this is a personal belief, okay? It's not something that you will find in a paper But I just firmly believe that if you are having any kind of study where a CHW is an interventionist, you need to embed them into the very fabric of the research team itself. With Tiffany, she wasn't just a consult, she was a co-investigator on the project. And Miss Muriel, although she was the interventionist deploying all of the facets of the intervention protocol, she also was embedded in the research functionings as well. So again, making sure that community health workers are at the forefront throughout the entire research experience. And to that end, we should also be sure that both the study team and the intervention site are equipped to incorporate CHW's expertise. And when I say equipped, I mean that we are creating a culture of inclusion that makes it possible for CHWs to feel comfortable to share their insights, to share their expertise, and to feel that they are being heard and validated, which is something that Tiffany has spoken beautifully about throughout our talk. And then finally, and I know this is a tough one, but I think it just bears mentioning, to the extent possible, if you are having a CHW as part of the intervention team, there should be some equity in the way that they're compensated. So I can say with confidence, having worked with the budget, that Tiffany made the same amount of money on this as me and Nakia. And it's because we view Tiffany as an expert and she deserves to be compensated for her expertise. One of the things that came out in that Able Foundation report was this idea that community health workers are underpaid because they're viewed as a cheaper workforce to get certain things done. But when you look at what they're actually doing, there's a level of sophistication and nuance that not is it's just not possible for everyone to do. I couldn't do it. I couldn't be a community health worker. I like people, but I don't like them as much as Tiffany does. And I have some empathy, but I'm not as empathetic and compassionate and tapped into resources the way she is. And that's how it is for many CHWs. So they deserve to be compensated at the rate that is commensurate with the extent of their expertise, which more often than not is very deep. Tiffany, did you want to add anything to this? Okay,
Nope, I think you said it all.
okay. So, in conclusion, it's really important to engage community health workers throughout the life cycle of a research study or a public health program. And doing so requires forethought, it requires intentionality, it requires those of us who are at the in the position of leadership or situated within positions of leadership within a team to be mindful of how you foster that sense of inclusion. Also, community health workers are natural leaders. That's what makes them effective at what they do. And because they're natural leaders, they need to be involved at every phase of a program or an intervention. And it's important that not only do the PIs recognize their expertise, every member of the team should recognize community health workers' expertise. Tiffany, anything to add?
Nope, I think you're wrapping it up with a bow very, very beautifully.
Okay, well, thank you. So I just wanted to acknowledge all of the wonderful partners who were part of the AFFIRME team, and you can see their lovely pictures here. And within the Hopkins and Maryland CHW team, we had Dr. Cooper, who served as a senior advisor. Dr. Brandon Smith was a co-investigator. We've spoken about Miss Muriel. Apologies, Dr. Pennant, I have your maiden name here, but again, she was the research program manager. And as an aside, she's the one that organized the symposium. She was incredible. Shruti, Tiffany, who we know and love, Shannon, and then last but certainly not least, Julia. So we're so grateful for all the people who participated in the program, for all of our partners. We greatly appreciate the Johnson & Johnson Foundation for funding this project and the Maryland Community Health Worker Association for being such an incredible partner on so many CHW initiatives. This is a picture of all of us together at various times. And that's it. Thank you so much.
Well, you can see all the applause in the in the Zoom room and in the chat. So everybody's really a lot of positive comments about this presentation. Thank you to both of you. I think you did a fabulous job. There have been a lot of questions in the chat as well. I don't know if anybody has anything to ask before we wrap up. We have about 5 minutes, but a couple of the questions that came up, I'm not sure if you guys are able to answer or if it would be more of a question for Dr. Nakia Shawel, but one of the questions was about like the percentage of people with type 1 diabetes, like children with type 1 diabetes. And then another one was about what percent of the patients are hard of hearing or deaf. And so
Yeah.
I don't know if you guys know the answers to those questions or not.
Unfortunately, I don't know the answers to those questions. They are excellent questions, but I don't know the answers to them. And I think Dr. Showell would definitely have some insight into that.
So are there other questions for our fabulous speakers? This was really very insightful, even for someone like me who I sort of think I know about how to engage community health workers, but this was really, really, I love the way this was done so intentionally and, with so much care. It really did in the sentiments from the team as well as from even the responses of the participants, the caregivers and the children. So yeah. People have asked whether we have upcoming events or
Oh, I think, if I'm not mistaken, Lisa may be frozen. Um,
Yeah, I'm also seeing her frozen on my side.
yeah. But I see Natalie has her hand up, so we're happy to answer questions.
Thanks so much. I noticed one of the papers that you mentioned that you're working on is about barriers to incorporating and some solutions around that in the pediatric setting. I was wondering if you could give us a little bit of a sneak peek at some of those conclusions and a kind of follow-on question. I feel like pediatrics as a discipline kind of understands the need to involve the family, whereas sometimes adult medicine disciplines lag behind, right? Because adults aren't always dependent on their adults. And I wonder, kind of if you have anything to say on that front.
Yeah, that's a great question. Thank you for asking. I'll start off, and Tiffany, please weigh in too, because you have worked in a lot of different settings. I mean, I think some of what we've learned about from AFFIRME and really from our partners as well at Family Health Centers is that there are a few barriers. One of the most critical ones is actually not the institution itself, it's the lack of funding for CHW positions, the lack of sustainable funding, and the fact that even when funding is available, the salaries are low. So it's hard to attract and retain people in those positions when they're not being paid what they deserve to earn. So that is one thing that um, that's a major barrier that isn't as amenable to intervention in some ways because it's kind of operating at a level outside of the clinic. Yes, different health systems could allocate money for positions for CHWs, but it's easier said than done. And I think we're going to see just how challenging that will be in the coming months. But um, some of the other barriers were things like people not knowing who a community health worker is, the perception that some of the things that they do overlap with what a community health worker does, and therefore the CHW role is redundant because they think it's that idea of creep, scope creep, like this is what a community health worker does versus this is what another member of the care team does, and a sense of, unfortunately, competition that can arise when things are not clearly delineated or there's not a strong sense of who is doing what in which set of circumstances. Tiffany, do you have anything else that you wanted to add? Just thinking about what we learned with the firm.
Yeah, I think when CHWs are truly embedded into the infrastructure, and everybody is introduced to the CHW, knowing the scope of practice, I think it calms the anxiety of other professionals, like your case managers and your social workers. I worked for FQHC who had multiple case managers when we were all hired, and within the first 30 days, they fired just about all of them because CHWs can do case management. Well, that's a part of what we do, but that's not all that we do. And so um, making sure that the organization truly understands the scope of practice for CHW and how to effectively implement them, add them into your business, and to use them for what they're good at, not necessarily for what you are missing as far as a gap in a position. I think what really help CHWs feel seen, heard, and what make us want to stay. We'll stay when we feel like we're supported and we're
Mhm.
valuable.
Can I add to what you just said, Tiffany? I completely agree. And the story that you just told of, positions being eliminated in favor of hiring CHWs and then paying them low wages, I think the other aspect of what you're saying that's so critical is that when everyone understands and appreciates what a community health worker can do, it allows everyone to operate at the top of their training. It lets doctors, provide the care that they want to provide, nurses and social workers to do the same thing. But when the lines are not clear as to who is doing what, that's when that sense of competition and frankly, scarcity comes up that creates this tension between different members of care teams. So I hope that answered your question, Dr. Spison, and thank you so much for asking it. And I
Okay,
see
we're going to
another,
take, there's a last question because we're at time right now from
oh,
Annie Hay.
yeah.
Mhm.
It's more like a comment, not a question, which Dr. Ibe, what you've just pointed out goes back to what I've been saying all along. I still don't understand why CHW workers are being paid less than a law enforcement officer.
Yeah. I mean, I don't know if you really want to hear my thoughts about that, but I'm just going to say them, okay? When you look at the sociodemographic profile of community health workers in the United States and even globally, they tend to come from structurally disadvantaged, marginalized communities. And if we are already placing certain people on the margins of society, and members of those communities are playing roles that are critical to different types of functionings, of course, they're going to be underpaid. So in the United States, most community health workers, the vast majority of them, identify as African American or, again, from the Latinx diaspora and identify as women. And the issue around payment is really, it's tied to a lot of other things. But the other thing that is kind of sobering is that there are disparities in pay even within the workforce. So white male CHWs tend to earn more than their counterparts of other, demographic characteristics. It was a study that came out, I believe, in 2024 or 2023 in the American Journal of Public Health. And payment is often linked to certification. This study found that white male CHWs who were certified earned more than other CHWs who were certified, who were not white and who were not male. So I think this is why when we think about incorporating or embedding CHWs within research teams, this issue of equity and parity and pay and all of these types of things that Tiffany and I have had the opportunity to outline today, they really all come together. They all play a role. So, I mean, that's my honest opinion about why they're not paid what they should be. And I know we're at time, so I'll get off my soapbox.
Hey, I actually do not see this as a soapbox. I see this as you telling us what it is.
Thanks. Um, so I think we're done, and thank you all so much for joining this afternoon. It's great to see familiar faces and to see new faces. And it was a pleasure presenting this with you, Tiffany. And
Yes.
please feel free to reach out if you have any additional questions or interest, and have a wonderful rest of your day and weekend.
Thank you, everyone. Have a good one.